Well, it's nice to be back. It was fun walking through the building and seeing the places where I used to go to lecture as a first-year medical student before they opened the biologic sciences division, and see all those old sites. It's certainly a pleasure to come here and talk about primary care and things that we're doing at Erie. One of the things I like to say is that we are trying to create the future of primary care at Erie, and so that's very much in alignment with what I was asked to talk about today. So I thought I should start by talking a little bit about Erie, because I know before I went to work there I didn't know very much about it. Our mission is here on the slide. At Erie Family Health Center, we believe healthcare is a right, not a privilege. Our mission is to provide accessible, affordable, and high-quality care for those in need. Just some high-level basics. We were founded in 1957 by medical students and faculty from Northwestern, and it's continued as a free clinic for a few decades. Was started on Erie Street. That's where the name comes from, and was inside buildings that are part of Erie Neighborhood House, which still shares kind of a neighborhood focus with us, and we still have a building that we co-own. But in the 1970s, Erie Family Health Center became its own separate organization and became one of the early fairly qualified health centers in Illinois. We do full scope primary care. I'm a general internist, but we have providers in all the primary care disciplines. We help with deliveries, take care of the babies in the nursery, bring them back for prenatal care, have a teen center for when they, getting the older end of the peds range. We have family physicians that continue to take care of them when they grow up to be adults, or they switch over to my team with the internists, and all the way up through geriatricians. We have been growing a lot. I've been at Erie for the last 8 years, and we've more than doubled in size in terms of our patients during that time. We have 13 locations now, and each one is kind of different than all the others, but 7 are large full scope primary care centers. The smallest is maybe 14 exam rooms in Evanston, and the largest is 34 exam rooms at our main administrative offices at Erie Westtown. All of them have behavioral health services embedded in them. I'll talk a little bit more about that later. And 4 of those 7 centers also have oral health centers with 5 to 7 dental chairs and dentists and dental hygienists. So we try at the big sites to be able to come and bring your kids for their child visits. It's a day off of school, so get that done, get their oral health taken care of in the same day, and try to be a one-stop shop. We also have 5 school-based health centers that are inside of high schools or middle schools in Chicago, and those are very different. They're usually 2 or 3 exam rooms, one provider at a time. We do have behavioral health services at those sites as well, but certainly they feel very different to say we have one school-based health center and we have one of these other centers. They're kind of apples and oranges. We do have the teen center, which is the largest adolescent health center in Illinois, and it's been there for decades and provides great services. We are also a teaching health center. We have federal funds from HRSA through the Teaching Health Center program. We were one of the 11 original grantees through that program. And that helps to fund our family medicine residency program that's housed at one of our sites, and all the faculty are Erie employees. So it's really kind of feels like it's an Erie residency under the Northwestern banner. And but we also have residents from many other training programs, including some of the folks here with us from pediatrics at the University of Chicago. Come to our Westtown sites. In total, if you add up all the residents who do their continuity clinics with us at all our sites, we have 100 residents now doing continuity clinics with us, which is great. It certainly makes my job, my number one job, I feel like, is to recruit great doctors to work for us, and it's nice to have that much exposure to the folks in training. I would say the thing that I'm most passionate about is our quality of care. I feel like in Chicago, if we were a kind of in a very rural area and we were the only provider, it's like it'd be just great to be there, so you could help people. But in Chicago, frankly, if we disappeared, there would be like another FQHC, half a mile down the street or something. And so I really feel like for us to kind of have a reason for being in existence, we have to provide something that's a step up from what people would be receiving otherwise in terms of what's available in Chicago. And, quality is not the easiest thing to measure, to say the least, but just as a kind of a sound bite or, about it, HRSA, the federal program that funds community health centers, the last few years they've had quality bonuses that they give to health centers based on their outcome measures that we have to report to the federal government. And this year, Erie received the largest quality leader bonus in the state of Illinois. And it was the 15th largest quality bonus in the country out of over 1,200 health centers. So we feel like, at least by that one measure, we're doing well. There's certainly things that we need to improve on. But that is kind of our passion at Erie. A little bit on our patients. We have 68,000 patients now and growing. Historically, Erie Neighborhood House, was one of the settlement houses that served immigrants from all over the globe. And more recently, the immigrants in Chicago have been from Central America and Mexico. And Erie kind of grew up in that same community. So we have, I think, if of people that know who we are around the city, the people who know us know us best are from the Latino community. So almost 80% of our patients are Latino. That's a little bit less. I mean, every site's a little different in terms of its mix. We have sites in Albany Park where there are people from, every corner of the globe. But nonetheless, that's kind of our roots. About half of our patients are pediatric. I think we need the Project Brotherhood to bring some more men in, but mostly our adults are women. And we do a lot of prenatal care, and in fact, just looking at the numbers, we deliver about one in every 30 babies in all of Cook County, and about 1 in 75 babies in the whole state of Illinois. We deliver at. We have five people on call every day at 3 different hospitals, just delivering babies. So we certainly do that a lot. I'm an internist, but sometimes I think, they just have the internists, do the administration and the meetings, because really it's like peds and, women's health are the main events for us. Like a lot of other community health centers, our patients are very low income. The vast majority are below the poverty line, and almost everyone is below 200% of the federal poverty line. even after the Affordable Care Act, we take care of a lot of undocumented immigrants, and so a lot of the adults, even though we've really tried to sign people up for insurance, there are a lot of folks that are still uninsured.
How did that uninsured figure change with Affordable Care? Did you see much of a bump or not?
Yes, I mean, especially from a finance perspective, the internists have always been the leeches on the rest of the organization, because if we see the most uninsured patients in Illinois, the kids are all covered. Even if they are undocumented, they'll still be covered when they're pregnant. But the internists, we see the folks that are uninsured. So it used to be more like 50% or more than 50% of an internist panel would be uninsured, and now it's more like 1 1/3, which actually does make a big difference for our ability to pay our bills. Sometimes people wonder, with the federally qualified health center, are we part of the government? No, we're an independent organization, which sometimes is good in terms of having the flexibility to change. But at the end of the day, if we run out of money, community health centers can go out of business. I think one thing that's also somewhat unique about Erie is we have very deep, extensive hospital relationships and academic partnerships. We do a lot of teaching, as I already talked about, research, a lot of resident teaching, medical students teaching. Some of the benefits to that are that, as we're negotiating, those kind of things that we can do for our academic partners, we also ask them if they can do some free care for our uninsured patients. And so we have 7 hospitals that will do free diagnostic testing and specialty care for our uninsured patients, which really is something that's I'm very thankful for every day. We try to do the best we can with primary care, but I think part of what makes us a good organization is we don't try to do things that we're not good at, and so there are a lot of things at a place like University of Chicago will always do better, and so we find partners who can serve the specialty care, diagnostic testing, and hospital needs for our patients. Another thing we do for the hospitals is we have our doors wide open for that uninsured patient with heart failure who's getting discharged, and the hospital's executives are thinking, I don't want this person to come back and make my numbers look bad for readmissions, and plus every time they come in the door I lose $10,000 or something. So we say, great, I will help you provide great primary care for this person, do the fine tuning of their medicines, try to keep them out of the hospital, and then, by the way, when they do need a CT scan or something, you guys do that for us. And that's sort of how there's not a lot of money that goes back and forth, but there's a lot of mutual benefit in these partnerships. As I said, we do a lot of inpatient care too. One of my, as I'll talk about later, I worked with Dorian Miller at Cook County for many years, and one of my favorite people there is Gordy Schiff, and one of his sayings was that at Cook County, sometimes we were so far behind, we were ahead. And I applied that to our model of care. We, almost everyone in the world has, ambulatory doctors and then the hospital doctors, but we still do both. We have, all of our inpatient teams are all staffed by people who do outpatient care at our health centers. And I know it's super retro, but the good thing is, all these hand-wringing about, how do you deal with these transitions of care? It's like simple, it's like, come see me next Tuesday, So it's, I think it's one of the things that helps our patients and our quality. So that's sort of the background on Erie. The focus of this talk was going to be on some just kind of very specific examples of things that we're doing to try to transform primary care. But I felt like the starting point for me is when I graduated from residency, I did a primary care training program trying to prepare myself for the work. My first job was at Cook County. I worked at the Austin Health Center of Cook County on the west side. Saw patients there for 8 years. And I just wanted to describe the model of care that was the starting point for me in my practice, which was we had some RNs and LPNs. They took people's blood pressure and they put the person in the room, and that was, pretty much, that was kind of the end of it. And there were a lot of doctors there, so they were, spending a lot of time just even doing those tasks and moving people back and forth and drawing blood and too. But we had no, there certainly wasn't any oral health services on site, let alone, available to the patients nearby. There were no behavioral health services. Literally we had manila, folders, that they just sort of, whatever papers, my last visits, the old prescription, some, CT, was just like jammed into a folder and they weren't even in a particular order. I remember hiring at a certain point, my sister-in-law was like out of work, and I like bought a bunch of paper, charts that, were like real paper charts that had things organized into sections, and I hired her just to go through my patients and convert the folders into these paper charts, which was probably the most impactful thing I've ever done to improve quality for my patients. Because those paper charts actually, when they were organized well, were pretty awesome for people who've never used them. Didn't have to log in, You could just flip to the radiology section, everything was there like an instant. But nonetheless, literally they wouldn't answer the phone for the first couple hours because they were just checking the people in, and they didn't have time to answer the phones and check people in, so there were sort of these downtimes. There was no phones being answered. There was, limited access to anyone after hours. The no-show rates were super high, so they compensated by scheduling 1 million patients. And then, of course, the only day you remember is the one day of the whole year when, 32 people showed up and they all had heart failure and diabetes, and, everyone was waiting for 3 hours and didn't get lunch. And forget the day when, the entire schedule didn't show up and you were, not doing anything. But it was a stressful environment, and at the end of the day, I felt like the people I was working with were super talented. I mean, they were really high-quality clinicians who were well-trained. And then when I stepped back and said, well, how was the care? Frankly, we didn't know. One of the projects we tried to do was to just answer the question, how are our diabetics doing? And it took 9 months to answer the question. By then, we were so tired that, we didn't actually do anything about the information we gathered. So it felt like the quality wasn't that good. It was high stress, and I wanted something better. So I moved to Erie, and I've had a chance to be, to participate in trying to establish, a different model of care. Many of the things were in place when I came, but, to try to work on some of this too. Just to give a brief overview, and then I'm going to focus in on a couple of areas of change that we've done. Like everyone else, we have an electronic health record. Sometimes it's a step forward, sometimes it's a step backwards in terms of the organization. But we do put a lot of effort into our electronic health record. We own a company that implements the G-Centricity EMR for 34 health centers around the country. So we have a whole team of IT people through that develop all custom forms, to our specifications, and data people who can pull information out of it. So we have kind of a relatively sophisticated electronic health record implementation. Every provider has a medical assistant, and they do a lot of stuff. I mean, there are more supports per provider, and they're busier. As I'll talk about later, the medical assistants have the primary responsibility for a number of areas of quality. So I think another kind of shift in mindset from what I experienced when I came out of residency was, we will help you, doctor, but just tell us what to do. And so it was kind of like, okay, I got to make the whole list and, shout out orders to everyone, and then everyone will do the things I asked for. But the truth is I was so busy that I just sometimes I didn't have time to hand out the orders and tell people what to do. So instead we say, you know what, flu shots, you know, that's not the provider's job. It's the medical assistant's job to get the flu shot done before the patient's seen. And then the provider doesn't have to talk about the flu shot because, you know, it's already given. Or they at least try, and then if I'm the second person asking about it, then, you know, it makes my job a lot easier. I find a lot of people who refuse initially, you know, if they feel like everyone in the world is saying flu shot's a good idea, maybe they should do it. As opposed to if I'm the first person bringing it up, it felt like it wasn't always successful. So they do, you know, for a diabetic, they'll do an A1C test before the patient's seen. You know, if they're on Coumadin, you know, they'll check an INR, you know, as well as urinalyses, and they do, you know, in the peds team, they do, you know, they do some surveys and things. I understand. I'm an internist, so maybe you'd have to. I hear they do something. Some of the, you know, routine screeners, ASQs, and so some of the behavioral health screeners and things like that. So that, you know, it's this idea of, you know, you're not there to wait for me to tell you what to do. You've got a whole bunch of stuff, and I have a whole bunch of stuff, and then we work together as a team, which I know is not an original idea, but it's something that's made a big difference for us. And then there are other administrative support too that, you know, do other aspects of it. You know, and then our nurses, instead of, you know, taking blood pressures, they are really kind of the front leaders of the care between the visits. So, you know, they're the ones who are going to be doing assessments with patients, triaging, engaging other team members to take care of things. Hopefully complex issues that are, you know, at our RN level. You know, we have oral health, behavioral health, as I said, on site. We also have lawyers. We have legal assistants. We have a medical legal partnership that we just won the National Medical Legal Partnership of the Year award this year. It's exciting. So we have two full-time lawyers who are just based at Erie, and then they have a whole network of law students and legal aid organizations that they refer patients into. So you know, often when I'm at the site where I see patients, I actually like see a lawyer in the same room as you know, we can run cases by her, which is amazing. We do, you know.
What kinds of things do they help patients with?
Well, I mean, one of the, you know, focus areas in the last year, I mean, especially in peds, is you see, they, you know, identify a lot of people with lead poisoning, and that's certainly in the news right now. That's Flint. But, you know, here in Chicago, there's still a lot of lead toxicity too. And so, you know, we know that our peds team and, you know, family medicine team will diagnose lead poisoning, but at the end of the day, if it's an environmental exposure, and, you know, undoubtedly if they're low-income people, they don't own their own houses in general, they're living in an apartment, you know, their landlord's responsibility to address the environmental exposure issues. You know, if the tenant, you know, who's living below the poverty line calls up their landlord in a probably not the fanciest part of town and asks them to, you know, fix up the place and address the lead issue, they might respond or they might not. But if our, you know, legal team calls them and says, hey, this is the housing code, this is your responsibilities to your tenants, you know, then kind of like, oh, lawyer? Okay, let me get on that. So we'd almost never have to sue someone, but just having them engaged often just accelerates the process of that kind of thing. They help people who were denied benefits, you know, when they shouldn't have been. They also do advocacy work. I don't know, probably no one saw this, but there was on the front page of the Tribune, you know, just a few weeks ago, there was an article on the Chicago Housing Authority changing their lead cutoff levels, and that was actually our, you know, medical legal partnership that advocated with the Chicago Housing Authority and got them to change their cutoff for what they consider kind of a dangerous lead level from 20, which apparently is really bad, to 5, which is kind of the, you know, modern standard. So that was, so, you know, they take these individual cases, they do advocacy with officials, they do a lot of stuff. Housing, you know, try to help people with housing issues. I have a whole other talk on that. We can do another day. We do phone and text reminders for gaps in care in between visits. You know, as an internist, like one of my favorite things is we do outreach to our diabetics. They We have an algorithm that, takes the two basic things are, how are you doing, meaning what's your last A1C, what's your last blood pressure, and then how long has it been since we've seen you. And then, if you're doing really poorly, then we start to do outreach to you pretty quick. If you're doing really well, then we wait, 6 months before we start to ask you where you've been, so that we, get the patients that are doing worse to have frequent visits to get the medication titration and things like that. We do different kind of scheduling. We don't schedule patients way in advance. It's sort of a modified open access kind of scheduling, which leads to a lower show rate. So we actually schedule fewer patients than what when I was at Cook County, they would schedule a third more patients per half day, with the goal of seeing the same number, but it just makes it a little bit more livable, less variation from day to day in terms of the patient volume to reach the same target at the end of the year. So not easy, stressful, but overall it's nice to feel like there's a team supporting you. There's, people, not all the responsibilities on your shoulder, but there are other people that can do these things to carry out the care. So I'm going to talk about a couple of specific examples in a little more detail. The first is our behavioral health implementation. Second is what I call the strategic plan for quality, which I'll talk about in a minute. And then kind of the next thing that we're working on, which is team documentation or scribes. So behavioral health, every year, one of the things I do is I ask all the Erie providers to say, what do you think is most important for us to do as an organization to improve, to be better as an organization? Kind of keep that vague. It might be more vacation for the doctors, or it might be, more education for the diabetics or whatever. Repeatedly, the number one priority that people rank is expanding behavioral health services, whether it's psychiatry, more therapists, is almost every year number one. And this is, mostly the medical providers, not just, the behavioral health people saying we want more of us. And so, that's becomes, as the chief clinical officer, that's becomes my to-do list for the year to figure out how we can expand our behavioral health program. So the first stage was we hired therapists that are at all the sites. So we now have 20 behavioral health, therapists at our sites that see patients. Our model started out as I would see the patient, they have depression or anxiety or some other problem, and then I put in the referral in the electronic health record, and then a person calls them and arranges the appointment. There was a waiting list. Eventually they get scheduled with the therapist, and then they get the therapy, which was pretty good, but the waiting list was long, and then the show rate was very low, and so we had a lot of therapists, and they actually weren't seeing a lot of patients, and it was, if I saw someone and they were kind of afraid of seeing a mental health provider, I could talk to them about it briefly, but I'm busy too, and so sometimes they were like, I probably need that, but I'm kind of afraid of it. I'm not gonna, I think that contributed to the show rate problems. So the second phase was, now we have warm handoffs. We now have kind of two job descriptions for our therapists. One is the behavioral health therapist, kind of what I described. The other is behavioral health consultant. The behavioral health consultants see patients during the medical visits. So now when I see someone with anxiety, I say, wait here for a minute. I'm gonna, is it okay if I bring in a therapist? They usually say yes. I go get the therapist. They come into the room, and then I run off and order my labs or move on to the next patient, and then they will do a further assessment and say, you thought it was anxiety, but actually it's something else, and they also will do brief interventions with the patient to try to provide some immediate relief, and then they'll connect them to either long-term therapy or come back and see me next Tuesday, or whatever they and the nice thing is then the patient's less scary, because they're like, oh, you're not scary. I thought that behavioral health the staff would be scary, but you're okay. You know, and in many cases, our patients prefer, language is Spanish, and so the therapists all speak Spanish, so it's like, oh, okay, and you speak my language better than Dr. Buchanan, and so that has really helped. Now the therapists are busier, because the show rate is better. We're providing more services, per therapist, and it's a great relief for me too. And a couple months ago, I had a patient, very interesting patient, had dermatomyositis that I was, he had a lot of prednisone and things, and one day, he came in and wasn't doing well, and was homicidal, and I just pulled in this behavioral health consultant to see him, and then I ran to see the next patient, and then an hour later, I bumped him in the hallway. He said, "Oh yeah, we're admitting him to the psych hospital." I'm like, it's like that's a miracle, I would have, I just saw 2 patients, while you were doing that, and normally I would have been stuck in the room, and it would have been like, been a disaster for everybody that day. We also have introduction to therapy classes. If there's a behavioral health consultant that's either not available, or even if they are available, sometimes we have patients come to these classes where they learn a little bit about the breadth of behavioral health services, understand more of the commitments, sort of the services, and then if they kind of go through that, then they can be paired with a therapist right away. That's the way we've eliminated the wait list for the traditional therapy appointments. It's kind of like in a drug trial, they have the run-in period, where they sort of say, you got to come to these 3 visits, or two visits or 1 visit, and then if you come, then we'll randomize you. They don't randomize you until they know you can actually show up for a visit. So that's sort of a little bit of the concept of it. It's really helped, make it easier for people to access the services and get them in quicker too. So a lot of our medical providers have told me that literally they'll say, oh, the behavioral health consultant in my clinic, that person is the best thing that's happened to me, as a primary care provider in the last 5 years. And one of the behavioral health consultants just won our kind of Provider of the Year award at our holiday party last week. So it's very popular. The other thing I wanted to talk about is something I call the strategic plan for quality. So, I've got to work with some kind of quality improvement researchers on projects in, colon cancer and diabetes and various, cervical cancer. And we, did a lot of great work to improve a very, focused care, in a particular disease. Like for colon cancer, we had a, NIH, I partnered with David Baker at Northwestern, who had an NIH center grant to do, primary care quality improvement research. And, the kind of main study in that center grant was doing colon cancer screening research at Erie, and we did like 10 different things to improve our screening rates, and worked on it for many years, and it was great. But we did that for diabetes and these other things. But then at a certain point, we both sort of stepped back and said, "Wow, that was a lot of work. It was very successful, but we haven't done anything about asthma. And there's like more asthma patients and then we could list 20 other things that were also priorities. And I was sort of counting, how many years left I had in my career, and like, I don't think I'm going to get to all this stuff, if each one takes 5 years. And frankly, I would think of something I worked on 3 years ago, and I was like, is anyone, still doing that thing that we put together 3 years ago? And so I kind of felt like, if I just did each condition or screening, one at a time, we were going to be kind of chasing our tails and not really ever getting to the point where the whole thing was making sense. And, but that was sort of depressing, but I did feel like we learned a lot from those individual projects about how to, what I call tactics, like we figured out how to send text messages to our patients to remind them about the colon cancer screening, the FIT test or whatever. And then we could use the text messages for our teen center patients to remind them of their appointments, because they, when we sent them automated phone messages, they were like, I don't answer the phone. What are you guys thinking? So, we sort of learned how to implement different tactics for quality improvement. But what we needed was an overall plan for how to utilize those tactics we had learned how to implement, and how to, what to do across all of our priorities. So, primary care is vast. And so when we got our kind of provider leaders together and we said, what are the priorities? We worked for several months and we narrowed it down to 51 priorities. And, and I guarantee if you looked at the list, you'd say, well, why isn't such and such on here? There's some, there's a lot of good stuff on there, but it's really, the scope of primary care is vast. We also, one of the kind of tactics that was most successful that I already talked a little bit about was engaging non-physicians or non-providers in the quality process. That was far and away, anytime we, move the authority from the provider to one of the other staff members, the quality always skyrocketed. I mean, the flu shots or something. It used to be like, the provider have to tell the MA to do the flu shot as soon as we said, there's a standing order, just give the flu shot. Our flu shot rates doubled or something, It just, I think there's a lesson in that, But at the end of the day, it's just, I feel like it's, the more we could do to broaden the number of people working on quality, the better. And to have each person who's working on quality working on fewer things. It might not be a few things, but fewer than, the overwhelming list of priorities that we have for us. So the result of that is this, which, I know you can't read it. Don't squint. I did bring some copies that if anyone's interested afterwards, I can show you the actual, that this is a real thing and not just a bunch of blurry lines. But, you couldn't, I guess you could pass these things around if you want to look at it. But the, what this does is the column over on the left are the 51 priorities, which I don't think they all fit on there, but on this slide. But, and then, if you could see it, you'd see that up here are the different staff types. So this is medical assistants and providers, nurses. I can't even read it. I don't know what's on there. Providers, lab personnel, our data departments, the kind of administrative support staff for the care teams, our health promotion staff, and our case management that's like the state-funded case management where they have a very defined scope of what they're allowed to do. So that's 1, 2, 3, 4, 5, 6, 7, 8, 9 different kind of staff member types. And then we said, well, for each one of these 52 areas, who should we delegate the responsibility for this care area? If it's a flu shot, give it to the medical assistant when they come in, but also give it to the lab personnel because maybe somebody didn't have a visit, but they had a blood test, and or they had a visit, but they were didn't have the flu shots yet, and then a week later they come in for a lab test, and give it, ask them if they want it then, and just give it to them. Or maybe they asked, the MA asked, and the provider asked, and they said no, but then the third person asked them, and they're like, well, if all you guys think it's a good idea, all my friends think it's a bad idea, but maybe I'll take it from the lab personnel, or maybe the lab personnel actually has a better relationship, or somehow connects in a different way. So.
And the lab person gives the shot.
Yeah.
To the cross-trained.
Yeah. I mean, not too. If you can draw blood, you can give a shot. I mean, it's a lot. I can give a shot. I don't know if I can draw blood anymore. But so this is kind of our really a roadmap for how we delegate the top areas of quality. And then within each staff type, there are even more columns, which is a description of the tactics that we would utilize to help support that person's success. And there are, I would say, if you looked at this and you actually came and checked what we're doing at Erie, like half of the stuff we're doing and half of it is to be done. But just to give an example, I think I zoomed in. So for like the medical assistants, an example of the tactics would be that for the flu shot, we would have a standing order so that they could just give it and not have to ask anyone. We would also give them decision support. So in the electronic health record, to make it really easy, we have like an MA view in the EMR that just shows them not everything, but just the stuff that they need in order to implement their standing orders. So they can say, oh, no flu shot. You want a flu shot? Yes? Okay, there's a flu shot. And then the next step that we want to do, that we had some technical challenges with, but we just figured out how to solve the technical challenges, so I'm very excited, is we want to give this medical assistants feedback to say, you had 200 chances to give flu shots this month. Great job, you did 90 of them, or you did 190, or we can give this to them personally. We can say you're the best on your team, or you're the worst on your team, and we can give that to people's supervisors too, so they can. So that, often when someone's not doing it, it's because they weren't trained, and things like that. So they can say, oh yeah, I never trained that new person in this. Let me remind them. So we want to give that feedback to close the loop, so we can say you really are responsible. We're even giving you feedback to tell you how you're doing. And then we can, potentially even have, an incentive plan someday that supports, that rewards people for, excellent performance in the areas we delegate to them. We do have an incentive plan for providers that relates to their areas of required, of focus for quality, but, a future step would be doing that with medical assistants. I know we're getting close to the end. Next thing I'm working on, very excited about, is team documentation. So instead of having one medical assistant, have 2 medical assistants, have the medical assistant check the patient in, stay in the room, do all the typing while I'm talking to the patient, actually looking at them in the eye, and and then they stay with the patient, do the post-visit work. We hope that would actually build an even closer relationship between the medical assistants and the patients, so that then the medical assistant could also do more of the between visit work as well, because they would spend more time with the patient than anyone else. They would have a panel of their patients that they could do some of the outreach to. If someone doesn't show up for a couple months, it's like, oh yeah, I know that person. Right now, they certainly get to know the patients, but they kind of miss the most interesting part of the visit, which is when the provider and the patient are talking about things. So that's not going to be coming to Westtown Peds this year, but we are going to work on that.
So the MAs will work as scribes?
Yes.
Okay. And they will be trained for that beforehand, I assume?
Right.
But this is not yet done?
This is in the design stage.
Has it ever been done anywhere else?
Not at Erie. I mean, I've talked to people at other places. Some of the challenges are that, as we've been modeling this to figure out the finances, it's, certainly before the Affordable Care Act, one of the things that I learned, doing like financial analysis of our care model and things was the busier and faster the internists work, the more money we lost. Which was like, oh yeah, so because I thought like, oh, we just see more patients, everything will be fine. No, actually, the best thing is tell the internist they have the day off, and we'll be better off. But it's a little different now with the Affordable Care Act, and so we are trying to figure out, but not entirely different. So we are trying to figure out how we could pay for the extra staff by squeezing in a few more patients, but with the extra staff members, we believe that would still improve the provider experience. So that's what we're going to be piloting in the next year to see, figure out how to do that. If see if it works.
Can you explain that the internists lost more money? Was that because of test ordering or?
Well, because the patients were mostly uninsured, we asked them to pay $30 for a visit, but they would pay $19 on average. You know, the labs, paying me, paying the medical assistant,
So it
call
was the
center.
fact they were uninsured with a minimal self-pay that wasn't paying for the cost of seeing them.
Yeah. Yeah, so, some of the patients had insurance, but not enough of them. Like the average revenue per visit was essentially below the average cost or the incremental cost of providing another visit. So,
So it's just because adults were uninsured. It isn't the nature of internist versus pediatrician.
exactly. The pediatricians, because of, it's a public policy decision that the kids would have insurance, the adults wouldn't. And so if the pediatrician saw more patients, it was great. The internist, it was bad. So next steps, well, everything's changing in healthcare, certainly in the safety nets, even more so in Illinois. We are transitioning from fee-for-service to, all of our patients, we have like 40,000 patients that that used to be in fee-for-service, and now they're in managed Medicaid, and we had to contract with these companies, and we, became a part owner of 3 companies. I was the board chair for Together for Health, which was this coordinated care entity, which was sort of an insurance company, and that's basically gone out of business because of the state cut the funding for all the coordinated care entity programs and lots of stuff we don't have time to talk about. But there's there's a lot of work, and to some degree I feel like it distracts a little bit from the quality work that is my real passion. But at the same time, we can't fall behind on that as an organization, or we'll be in trouble. We've been part of the way I think to succeed in managed care is to be big enough so that the payers, the insurers, notice that you're there, are willing to sit down and write up a more novel contract, that gets away from fee-for-service. So we've grown. When I started 8 years ago, we had 28,000 patients, and now we have 68,000 patients. There's a lot of health centers. Some of them might even merge to get bigger, to get more market share, just like the hospitals are doing. And then another thing that I know we have to do someday is, not just do more and provide better quality, but also look at ways we can provide different models of care to different patients. Because some patients, have a lot of chronic illnesses. They need very intense care to keep them out of the hospital. Some people, they're really healthy and they exercise a lot. They just need to get their well child visits for their kids, get their routine screening done. And frankly, they don't even want to see a doctor to get that stuff. If we could just make it easy to stop in, get the stuff done, right away, they would love that, and that would actually be a cheaper way of delivering health care. So how can we do both of those things? Actually provide a kind of lighter touch, more convenient, model of care to the healthy patients, and simultaneously, spend 3 times as much per patient on the sick patients to keep them out of the hospital. So that's a totally different kind of, management challenge than fee-for-service, where it's like, it's just like doing visits, and you get paid by a unit, and it's more complex. It makes it more interesting to be, an administrator, but it's also a challenge, and it's not clear how to solve it, and it's not clear who's going to be paying and how much, and it's a lot of chaos right now. One thing, just to step back, the last 60 seconds or something, that I think is a challenging scenario for community health centers in general, including Erie, is before, if everyone had fee-for-service Medicaid, they could go wherever they feel like they get the best care, So they could come to an FQHC, they could come to Erie. If Medicaid managed care, people have to go to the primary care providers that their insurance company contracts with. If we don't kind of jump into the value-based, arena of looking at capitation and global risk and things like that, if we just get into a situation where the insurers are saying, who provides the cheapest primary care visits? That's not what we do. I mean, you know, the care model that I described is not the cheapest. I mean, it's, you know, primary care is cheap in general, so we're, you know, a tiny fraction of the healthcare cost pie. But if you're, you know, manager and you're just asking the very focused question of who can do a, you know, who can see this person for their, you know, allergic rhinitis for less money, then we're not going to do very well there. So, you know, either we have to, places that are doing more innovative, complex, you know, more robust primary care have to move into a capitation kind of scenario where if we keep someone out of the hospital, we can get additional revenue and that can allow us to survive. But if we kind of, if the world doesn't change, which, you know, everyone says, oh, it's going to value-based contracting and stuff, but is it now? No. So, you know, if it stays kind of chaotic and fee-for-service, eventually, you know, we may be in kind of trouble. So that's the, you know, something that's on my mind in terms of a challenge and that we're trying to solve. So happy to talk about any of that stuff. I know some of you guys probably have somewhere to go, so but I'd be happy to answer questions, or if people need to leave, feel free to, and I'd be happy to answer after. Dorian.
So I have a question. It has more to do with your intro in terms of your background than anything, but leading up to the work that you're doing now. How do you think both medical school and residency prepared you for your current position, and if there were things that you would have done or could have done differently along your career trajectory, what would those things be? Big loaded questions, I know.
No, it's a great question. I was talking to some people at the beginning before we started a little bit. It's, you know, I loved coming to Pritzker for medical school. I felt like, you know, learning anatomy from paleontologists and, you know, learning internal medicine from some incredible teachers. I felt like I had a great basis of clinical training. I didn't, at the time, have great mentorship in primary care kind of, I mean, even the people doing primary care basically told me not to do a primary care training program, you know. This was a long time ago. I know it's changed. So, you know, there was a little bit of me kind of having to say, well, I think that's what I want to do. Why don't, you know, maybe I'll get trained in the thing I want to do, even though people that are older and smarter than me are, you know, telling me it's not the right direction. So part of it was, you know, sort of persevering, I guess, against that more than, but then, you know, being in a primary care training program was very different. It was like, those were the people that, they didn't do that, you know, you wouldn't volunteer to be a faculty in a primary care training program if you didn't like primary care. So that felt very supportive. You know, it felt very much like, you know, I found the people that could mentor me and help support me. You know, I've had a bit of a wandering path, I think, since, you know, graduating. I feel like, you know, I did research for some years, which I didn't talk about today, but on homelessness and health impact of housing and things like that. Instead of having a master's in public health or something, which would be the obvious thing, I have a master's in clinical research. So, you know, but I feel like, you know, sometimes all these experiences you have sort of help prepare you for things. You know, sometimes if you just, like I'm glad that I was an economics major instead of pre-med major, because, you know, like I actually love spreadsheets, and you know, I know all these, you know, approaches to financial problems that we have to solve at the health center, and like I generally do more like the financial modeling than our CFO does, because I just love that, and I, you know, feel like that's where I have some skill sets in it. So I think one thing that's been nice is having different mentors in different areas and people with different skills, and sort of, and then bringing that into a management role where I can try to use those talents. Mentorship certainly has been very important from you and from, you know, Avery Hart, who works, who now works at Erie, and other people at Cook County, and so I don't know. I'm not sure if I'm coherently answering your question, but I guess one thing I wish I had had that I think you guys are starting to build is, and I think we need at Erie too, is we have very smart doctors who are finishing their training or early in their career, and they want to be in management roles in primary care and in community health centers. And their training generally did not prepare them to do that at all. And they're definitely smart enough and talented enough to do it, but they do need some kind of I think like a ambulatory care management fellowship or training or something like that. And if someone wants to put that together, I would be happy to help with that, because I think we need to, that's something I was lucky enough to have a boss who, Lee Francis used to be the medical director at Erie. He's been at Erie for 20 some years. So I walked into this job, and my boss already had my job for a long time. He could tell me everything I needed to learn. But I see a lot of medical directors and health centers jumping into the job. The CEO is not a clinician. They've never done the medical director job, and they're kind of like struggling, even though they're smart enough to do it. So I think that would be something I would like to see.
But we'll have a Lucent fellowship slot funded through this grant, and then also we'll have a cohort of residents that will be doing some different projects that could include primary care management. So we will definitely connect you.
Great. We would love that. Hi. Yes. I was here on Tuesday.
I know you said something about primary care shortages.
Yeah.
The AAA.
Right.
And sort of the idea of the quadrupling, which is physician satisfaction. And talking about the scribes in your checklists are great, but what else are you doing sort of for physician satisfaction, to increase physician satisfaction?
Well, when I was at Cook County, a lot of my time when I wasn't with patients was involved in teaching, and I am passionate about teaching. And people think that the reason we have so many residents is because is because that I'm passionate about teaching, which is kind of true. But the truth is, there's a primary care shortage, and if we train a lot of residents, then we'll be able to hire great doctors to work and take care of our patients. So it's really about that. And even before we graduated any residents, we were able to recruit people to say, hey, working in the safety net, it's hard, but it's very rewarding. How about you come work for us full time, but on Thursday, instead of seeing your own patients, you work with the residents in the precepting room, and they're like, that sounds more sustainable and more doable. So that's definitely part of the model, that I'm trying to build, is to give people nuanced job descriptions so that it's like you do some, important, hard, good work, but, one day of the week or something, you're doing something different to keep you engaged, give you a shift of gears. So that's critical.
Primary care salaries are going up too significantly over the last 5-10 years. Primary care salaries, both because of demand and because of increased incentives through the Affordable Care Act. So they are going up, which is good.
So in your primary care residency teaching part that you do there, internal medicine, what is it that you think is special that's helping you train the docs that you want to hire? Because I know in family medicine Erie's been very successful at just unknowing in the internal medicine part. Because part of the internal medicine training challenge is not enough time in ambulatory care.
Correct. I mean, we do continuity clinics for about 35 internal medicine residents, and definitely the level of engagement, with Erie and the health center is far less for the internists than with the family medicine folks. That's a little outside of my control, but we try to. But it's certainly something we notice, and makes it harder to provide patient care when they're not there very much. And but I think by trying to, part of what I still try to do in those situations, even though it is a harder challenge, is to convince the internal medicine residents that outpatient medicine is interesting and complicated and important. You know, I think one particular residency, we became the continuity clinics for this residency, and at the beginning they were kind of like, how fast can I get out of here so I can go back to the ICU? And I think a few years later now we're kind of at the point where they're like, to think about what am I doing this visit and next visit and how this connects together, and I'm not saying we're all the way there, but that's an important goal too.
I'd be interested if you talk a little bit more about how you've managed the very fluid relationship between insurers and patients and providers in Chicago.
Yeah.
So I have some experience at Miles Square.
Yeah.
And U of I, we tried to put together a insurance plan that was pseudo attached to the health system and sort of separate, and it didn't go as well as hoped. And I was wondering how you guys have approached taking on your own patients directly, or how you navigate managed care plans changing every half cycle. Yeah,
that is a lot of work. I mean, it's an interesting intellectual management problem, but it's a total chaos for the patients. And so, I mean, some of the ways we've responded to that is, our first response was contract with a bunch of companies, because we could advise our patients, but we couldn't control where they were going to land. So we wanted most of them to end up being able to stay with us regardless of where they landed. We became a co-owner in the MyCare ACE. We're part owner of the Together for Health coordinated care entity. But we're also in leadership positions with the Lurie, CCE, and with the North Shore Community Care Partners, ACE, at the board level for all those things. So our first reaction was, well, we'll spread out and cover as many of these as possible. We're part of the co-owner of the Medical Home Network, ACO. And I think it was a good approach, because some of those that I thought were going to be really successful, now are either gone or half gone, and others have done really well, a few. And so now we're it was first like throw a big net, and now we're trying to think about how can we pare down the number of payers and partners to have kind of a more cohesive network, and have our patients and fewer payers, so there's fewer contracts and relationships to manage. And that's, so now we're in that phase of kind of contracting a little bit.
Who's doing like a really bang-up job? Like, who are you, like, that's the payer that you'd like to model everybody after?
Well, I mean, my favorite payer, I don't know if it's necessarily the same question, but our favorite is county care, because half of the county care patients are in Medical Home Network, which is this ACO that we're a part owner of. And the Medical Home Network ACO is very well run, and they have a great contract between the Medical Home Network ACO and county care that does allow us to have some flexible funds to change our care model, and then to be rewarded if we succeed. So that's that's my favorite right now.
I want to leave some time for people to network and talk individually, and please get some refreshments, and then people can still ask Dr. Buchanan questions if you have more conversation.
You said one probably grown up with the electronic medical record. On a busy day in the clinic.
Yeah.
Because one reason I can think why, as an internal medicine resident, I'd rather go back to the ICU to the community clinic, is that I got a captive audience, and I got all day long to put my
Yeah. Yeah.
So in an ambulatory setting, the word scribe was mentioned 10 minutes ago.
Right.
What are your thoughts on the pros and cons of the EMR from your standpoint right now?
Well, I mean, like everyone else, sometimes I hate it, but it's very obvious it's not going away. I mean, we have a great data department. So, I mean, as an administrator, I see the tremendous value in knowing what's happening with our patients, what's happening up to the minute with our quality. You know, I can, on all the quality indicators we track, I can, you know, instantaneously look at the site level, I can look at the provider level and kind of see what's happening. That's amazing. I mean, with the paper charts, we had no idea what was going on. But in terms of the efficiency of delivering care, you know, to an individual patient during the visits, it's worse right now, you know. You know, we are, you know, Erie is a part owner of the Alliance of Chicago Community Health Services, which is, you know, we're one of 4 owners that, and that organization implements the GE Centricity EMR at health centers around the country. And because of that, we have kind of a special relationship with, you know, GE, and we develop all the forms ourselves. And so I kind of see that this is going to get better. You know, like our EMR, the infrastructure of it is built on a coding language that GE developed, like, you know, 20 years ago or something, and it's kind of reached the end of its usable life. And you know, but they're going to switch to a different, you know, more modern programming language that can give more flexibility. And that's not just true with GE. I think that's true for probably all the EMRs. So I actually think we are going to, it's going to get better, but it's not tomorrow. You know, I think 3 or 4 years from now. But that is kind of hopeful because I didn't see that light at the end of the tunnel a year or 2 ago.
So I want to thank Dr. Buchanan and stay and have some